Thank you everyone for coming back very quickly. We appreciate that. I know that having a chat and talking to other people is actually really important at these events because we all work very hard, and it's actually really good to actually talk to some other people as well, rather than just be at the desk in the office. At least that's for me. This is, I'm let out today. So thank you for joining us again. What we thought we would do is we have a panel here who are each going to speak for a short time, and I'll introduce the whole panel to start with so that you know who's up here. So next to me I have Sherilee Mitchell, who's the Director of Family and Domestic Violence Unit, Strategy and Policy at Department of Communities, the new Department of Communities. Iscel, who's an educator and trainer at the Women's Community Health Network WA, and specifically working on a project around women with disabilities. Then we have Simone Bastin, who's Director of Strategic Service, Department of Communities Disability Services, and we're all getting used to the new way of saying things. We have Eleanor Ingram, who's the Senior Project Officer with the Substantive Equality Community Engagement Division at the West Australian Police Force, and Sergeant Steve Banks, who's also with the Community Engagement Division of the West Australian Police. And at the end, the lovely Fiona Payne, who is co-lead of the Disability Health Network at the Department of Health. And so thank you. Please give a round of applause to thank everyone for coming. And what each person is going to do is give a bit of, just a little bit about the particular area they're from, the current approaches and ways that they're looking at how to respond to or prevent abuse and neglect of people with disabilities. And this gives us then a sort of a bit of a where are we at now, before then after lunch, collectively us starting to talk about what else can we do. So my pleasure to introduce Sherilee Mitchell to start us off. Thank you, Sherilee.
Thank you. A very brief background from my perspective. I've been working in the family and domestic violence area, different roles, from establishing the very first shop front and refuge in Victoria many moons ago, probably yes for ladies, probably over 35 years ago, and having roles working with women experiencing family and domestic violence, and then moving into government and having more of a strategic approach to the development of policy. So I have a real passion and commitment for this area, and I often say to people, you can go to university and get your qualifications and think, you're prepared, I guess, to work with women experiencing family and domestic violence. But that was a rude shock for me. I got most of my learnings working with the women, and I have nothing but admiration for the women experiencing this on a daily basis. And I guess my commitment is to make things better, to make women safer and give them equal rights in this area. During my journey in terms of work, I also worked in the disabilities area for a couple of years. And my role was to case manage families with children with a terminal illness. And again, I had gained a very complete compassion for families experiencing what they were going through. But interestingly enough, even in that role, I was confronted with situations of family and domestic violence all the time. So a lot of women who had children with a disability were also experiencing domestic violence from their partner. So that's just a bit of a background from where I've come from. So I've been in WA since probably about 1999, 2000, I think I moved here, and started with the WA government. So I head up the Family and Domestic Violence Unit, which is actually the FDV policy arm of government. So we support the now Department of Communities as the lead agency for this area. So I'm just going to go through the slides very quickly, so I'm not taking up everyone's time. The Department of Communities has been created since the election and with the new government coming into power. It amalgamates the Department for Child Protection and Family Support, the Department of Housing, Disability Services Commission, the Communities component of Department of Local Government and Communities, Regional Services Reform Unit and Youth Justice. So we're now one big department, and we're still probably going through a lot of change and uncertainty in how we are amalgamated to work as one department in this area. But again, with the amalgamation comes huge opportunities. So we're now reporting to 5 ministers as one department. And I guess for my area, which is family and domestic violence, just so thrilled to have a dedicated minister for this area since the new government came into power. So Minister McGurk has a very, very strong commitment to this area, so lots of opportunities ahead. So in relation to family and domestic violence, the unit's role is to support the broader department as the lead coordinating agency across government and community sector for strategic planning around FDV. We're also one of the main primary funders for family and domestic violence services within the community service sector. And we also represent WA in the development and implementation of the National Plan to Reduce Violence Against Women and their Children. So the National Plan was launched by COAG early 2011, and it's a plan from 2010 to 22. So when the National Plan was launched, I had a look at what we were currently doing in terms of strategic planning in WA and created what we're calling the Western Australia's Prevention Strategy for Family and Domestic Violence. And that's designed up to 2022. And it basically has the same focus areas as the National Plan. So in WA, it gives us an opportunity to look at the focus areas of the National Plan and start to look at what we can do here in WA to align ourselves at a national level, but also look at the needs for WA as well. So the action plans are actually designed around the focus areas of the National Plan. So we've also established a governance structure to represent FDV, and we've since the new government, we've had an opportunity to revisit what we had previously. And with the dedicated minister for FDV, we were able to look at what else can we do in terms of getting government and government ministers on board in this space. So if I work from the top down, we have Minister McGurk as the dedicated minister. There's also been the establishment of the Community Safety and Family Support Cabinet Subcommittee. Now, this subcommittee is where a range of ministers come together, and FDV's firmly on their agenda. Under that, there's been a Directors General Implementation Group established, and these two groups have only had up to 2 meetings so far, so they're still kind of finding their way. We are going to establish, and we're in the midst of establishing, an FDV Advisory Council, and this will be representation from non-government, so it won't have government sitting on it. It's an opportunity to get the voice of the sector and the community up through the governance structure of government, and it's an opportunity to raise the issues and put, as an example, women with disabilities firmly on the agenda. So as I said before, opportunities are here now. Underneath that, we have an already established FDV advisory network, and these are representatives from across government and the community sector, so that we can start to forge the relationships and have some seamless ways of responding to FDV. So the priorities at the moment that we're looking at are primary prevention and the implementation of the Our Watch Change the Story, which is a national primary prevention framework. Big focus on integrating service systems. So there's no wrong door and there's no duplication of services, and we're trying to eliminate the issue where women often have to repeat their story. Also, with integration, it's important to remember that we absolutely need to provide support for women and their children experiencing family and domestic violence, but if we do that in isolation of managing the risks posed by the perpetrator and trying to change that behaviour, we're actually just shifting the problem around. So integration means we look at the whole issue, and services need to come on board and work together to support behaviour change and to support women to safety. Information sharing is being streamlined to allow that to happen. We've also developed a domestic violence common risk assessment and risk management framework. So this basically sets a set of minimum standards for an agency to respond to when they're dealing with FDV, so that we can start to get consistency in our service response. And monitoring and evaluation is going to be really important, and what data we collect and how we can strengthen our data collection in this area to represent the different needs so that we can start to build an evidence base. So that's basically the focus. Now we know, and you guys would know this, the rates and types of violence against women with disabilities. The position that government takes both at a state and national level is family and domestic violence is a gendered crime. So we know more women experience violence at the hands of a partner or an ex-partner in this space. Men who use violence often target victims who they perceive are less powerful. So it's an issue of power and control, such as women who are unable to communicate to others what has happened to them, and those restricted in their physical movements. So women with disabilities actually have additional burdens in this space and additional barriers. Women and girls with disabilities are twice as likely as women and girls without disabilities to experience violence throughout their lives. Over 1/3 of women with disabilities experience some form of intimate partner violence, so from a current or past partner. Many women experience social isolation as both a risk factor for and a consequence of the violence. Some perpetrators use social isolation as a form of controlling behaviour. So for women with disabilities, this can be compounded. So what we need to do, and when I say we, government and services in this space, need to listen to women with disabilities. Women report that the most important help they received was that people listened to them. We need to empower women. Representation of women in staff, on boards and in all levels of decision making is a critical way to reduce discrimination and break down the power imbalances. Provide accessible information on the rights and services for women. We need to work together to remove the barriers for women with disabilities to access safety and justice. We need to understand the causes of violence against women with disabilities. The layers of power and discrimination combine with negative stereotypes. We need to address the discrimination. The environments and attitudes are often disabling. We need to take steps to reduce the access of these barriers. So the government's committed now to put women with disabilities who are experiencing family and domestic violence firmly on the agenda. But we don't know what we don't know. We're not the experts in this area. We need to get your voices across. How we're going to do that? So the plans at this stage, to kick things off, we're going to hold a forum in November, and we've engaged Our Watch. Everybody know what Our Watch is? No. Our Watch has been established under the national plan to develop a national primary prevention framework for gender-based violence. So each state and territory throughout Australia has committed to implementing the Change the Story framework. What we're going to do at the forum is organise a series of roundtables, and one will include a dedicated focus discussion on violence against women with disabilities. And as I said before, we don't know what we don't know in this space, and we need to learn from women who are experiencing FDV and the services supporting them. So there'll be invitations to the forum being circulated shortly. Women with Disabilities WA will be invited onto the FDVAN, which is the advisory network, and the newly established advisory council. So invitations will be circulated shortly. An issue that I guess for me always stays top of my mind is we've also got the issue of women experiencing FDV who have children with disabilities that we can't drop off the agenda here as well. And of course we need to focus on integrating our services, which means workforce development and getting our services more informed to then have the effective responses is going to be important. So thank you.
I'll ask if people have questions, jot them down and we'll save them for at the end of the panel. I'd now like to introduce Iscel. You can either stay there or come up to the lectern, whichever you prefer, Iscel.
I'll just stay here.
Okay, we just have a microphone there, and Iscel is representing... Sorry, I need my list. Iscel's representing the Women's Community Health Network of WA. Thank you, Iscel.
Thanks very much, Sam. So, the Women's Community Health Network, has anybody heard about us? No? So, what's that? Oh, cool. So for those of you who don't know, the Women's Community Health Network is a community-based women's health community services and other stakeholders. So it's women's health and other organisations. The role of the Women's Community Health Network is to engage in research, exchange knowledge and information, develop the workforce, so training, etc. We do systemic advocacy and community consultations. So I'm currently delivering the Doors to Safety project across the state, which is actually funded by the Department of Social Services. The exciting thing is that the Doors to Safety so it's a capacity building project, and it aims to start building the local capacity to respond to violence against women with disability and to just stop it, hopefully. So the project was developed by women with disabilities, and it's being delivered mostly by me. And I have a disability, as you probably know. And so the project is currently delivering sessions, capacity building sessions to the family and domestic violence sector, the disability sector, and also running some peer education sessions for women with disability, which we had last Tuesday. So what we've learned so far is nothing new to the disability advocates, just a warning. But what's important is that accessibility is a lot more than just physical access or providing, interpreter services for deaf people. It is more about, or also about how, and especially very importantly, how staff in service providers actually feel, not just in the disability sector but in the wider community, how they feel and think about disability, so their attitudes. And it's also about providing the right information for women with disabilities about services. It's about providing information in the first place, because usually there's information out there, but it doesn't come to us because we need information. A lot of us need information in different formats, presented in different ways. So, some of us need it verbally, some of us need it in writing but in easy English, some of us need it in Braille, all kinds of different ways that we need information that is not being provided at the moment. And we need to go beyond the development of disability action and inclusion plans. Everyone's heard about the DAPEs. They're very popular now. Everybody wants us to be involved in the DAPEs. But we need to go beyond that. It's actually more than just developing the DAPE. It's about infiltrating the services. I like that word because it means you go actually deep into the services and look at their policies, their procedures, their actual practices of how they do things. If we're serious about the inclusion of women with disability, we need to widen the meaning of access to include appropriateness, approachability and acceptability as core concepts. It needs to be, appropriate for people with disabilities. Sometimes, often, it's not. And we need to talk about what all that means. Approachability, what makes it easier for women with disabilities, or what would make it easier for women with disabilities to go to these services? And acceptability is what makes it acceptable to us. What will allow us to go and approach them in the first place? So by giving access a wider meaning, the mainstream services can be better aligned with what women with disabilities need. Because at the moment, I think it's not very much aligned, is it? So many women who come to tertiary response services, so that's like the FDV services, they have disabilities, but their disability is not officially recognised sometimes, or some people actually have acquired disability as a result of living with constant domestic violence. But some disabilities also, as many of us know, they're not very obvious. So people could have mental illness. No one walks around with a sign on their head going, I've got mental illness, do they? So it's hard to know. Unless people are trained, they don't recognise it. And being trained means not by looking at someone and saying, oh, they must have this, but asking and how to ask. And the women with disabilities can also have other life experiences too. You know, I'm a migrant. Other people are from an Indigenous background. Other people might be homeless. So having a disability doesn't exempt people from having other issues, unfortunately. So the tertiary response services don't really know at the moment a lot about disability. They know some, but not a lot. So meeting some of the women's specific access needs can be quite challenging for them. And at the moment it can be so challenging that they go, we can't do this. It's too hard. So that's what we are trying to address. So the lack of communication between the disability services and tertiary response services makes the collaboration very difficult when it comes to helping a woman with a disability. Yet high quality collaboration between tertiary response services like the FDV services or family and domestic violence services and the disability services is really much needed to overcome some of these challenges. So ANROS is the Australian National Research Organisation for Women's Safety, has done a research recently on the agencies who provide services for women with disabilities who've experienced violence. And they say that sometimes, the research has found that sometimes the things that service providers do to protect women from further re-traumatising can actually lead to less rather than more access to supports and services for women with disabilities. In order, for example, let's say, in order to protect women with disabilities, they might prevent them or stop them from going to visit, going to do things in their community. And that way, they don't get access to other women maybe. They don't get to bump into other women with disabilities and so on. So that's actually more damaging to try and protect women with disabilities by making them lose more access. From the perspective of some of the women that were interviewed for the research, they often said that they were denied information, they didn't have their experience acknowledged, and they were isolated from other women, so they couldn't share their experiences. When I say they didn't have their experience acknowledged, it actually means, a lot of a lot of women found that when they went to ask for help, people didn't believe them. And that kind of puts you off asking for help at all. So often too, a lot of the times, their ideas and opinions weren't even sought when services were trying to improve their service delivery. So it was a case of doing things without us. So the work done by ANROS in the case study of the action research phase shows how service improvements and cross-sector collaboration can actually be incorporated through careful consideration of the needs and good planning. Planning as to how do we provide those needs when someone comes along. So instead of just sending women off to disability services when they come to support, a process of collaborating and engaging with disability services was developed as a result of the project. So then, it wasn't a case of, oh, you got a problem. Often people would ring lines, helplines, general helplines, and they'd be told, oh, you go to a disability service because we can't help you. So with collaboration, that kind of doesn't happen. So this established continuous improvement and cross-sector collaboration is underpinning the principles for working with women with disabilities. So they are the core concepts when working with women with disabilities. So other key findings of the Andrews research included the fact that one shoe doesn't fit every foot, and there are very different access needs. There needs to be adequate time for counselling, case management, and the consultation must be permitted to meet individual needs. Because when you're consulting with someone with a disability, it might not be just a case of me sitting in front of you talking, or us two talking. Some people, if they can't talk, they have other needs. They might need assistive technology to help communicate. The research also found that women value relationships where they can build trust with staff. And that can mean that it takes time to build trust, and there needs to be that time. And finally, many women seek social support from others who have had similar experiences. So peer support needs to be supported and established. We do have some recommendations then that came out of the research. And I thought I had this, sorry, just bear with me. So the first recommendation was to provide access and accessibility. So that could mean that the services could be approachable and women are comfortable approaching them. And that they're acceptable and they're appropriate. So the recommendation 2 from the ANRO's research said we need to build cross-sector collaboration, like I said before, between disability and other services. The third recommendation was to involve women with disabilities in whatever the planning is for service delivery, but also to involve women and bring them together in kind of a peer support environment. And the last recommendation is high quality data collection. So when a woman with disability does come to a family and domestic violence service, that their disability is recorded and that their needs are recorded, so that we know how many women with disabilities come and what kind of disabilities, or more importantly, not what kind of disabilities, but what the needs are. So that can help in future planning. And that's it. Thank you.
And very interestingly, at the National Disability Services Conference earlier this week, there was research from Christine Bigby, who's a professor in the Eastern States, who was talking about even in supporting people with disabilities with support in shared accommodation, where the attitudes of the staff are seeing people with disabilities as other or different, then outcomes were usually worse for people with disabilities. So that attitudinal thing is really very, very important, yeah. And also the peer support backs up Jane's story really highlighted that as well. And I think the Doors to Safety project is one of those projects that's trying to address some of that collaboration, which we'll hear a bit more about later. So thank you. We now have Simone Bastin, who's Director of Strategic Services, Department of Communities Disability Services, that can tell us a little bit about what's happening in the disability services space around abuse and neglect, or how we respond and prevent. Thank you, Simone.
So my role as it was actually the Director of Strategic Services last week. It's a bit of a reflection of where government is at the moment. This week I'm back in the Policy and Planning Division, but it's good because I could probably cover numerous areas. I also spent about 5 years in the Disability Justice Service, so I have a bit of a broad perspective and have been in what was the Commission for 15 years. So I'll try and cover as many things as I can. What I was hoping to do is give you a bit of a broad overlay of where we have been and where the critical areas are for disability services in WA, and then a bit of a state of play of where we are looking to go to, because we are pretty much on the peak point of change in the disability sector, and anyone who's working or very close to this sector will realise quite significant things are happening in this space. So yes, I work for the Department of Communities now for Disability Services Division. I'll probably accidentally say Commission quite a few times, so please forgive me. Our Minister is Minister Dawson, who is the Minister for Disability Services. And probably one of the things that I wanted to say up front is I'm probably preaching to the converted, because a lot of the things that have already been said are probably things you already know. So I might sound like I'm pinching from everybody else's sort of presentation, but I think it's because the same common themes are coming up over and over again. One of the things that I think disability services is, again, structured to respond to is the concept about individualised empowerment and choice and control. And everybody hears this word, choice and control, reasonable and necessary. But it is around that person first and person centred approach. And it's really pleasing across the last few years that there's a lot of movement from other government departments into person centred approaches as well, which is really great. When we talk about individualised approaches, we're talking about empowering people in the information provision, the choices and the decision making, their advocacy, self-advocacy, as well as formal advocacy or informal advocacy supports, flexibility to make changes, just like anyone else in the community can make changes, and also, of course, protection, which is what we're talking about today. The way I liken our value system within disability services is the spoke and wheel sort of approach, with the individual at the centre, and then how can we support that person. So I'm going to go through, because I kind of thought, 5 to 10 minutes, there's so much to cover. So I'm going to go through some sort of highlight areas so that you potentially might want to come back and ask specific questions. And then there's 2 key areas that I'd like to focus in on at the request of the presenters around positive behaviour and elimination of restrictive practice, and then also the national direction around quality and safeguarding. So that's kind of where we're going to. So we were talking about prevention and how do we actually prevent issues occurring when we have that person at the centre. How do we actually make those things, encourage and support those things to be as effective as possible? The cornerstone, I guess, of disability services in Western Australia is individual planning and individual choice and control, and people having the power to make those choices themselves. And alongside that, obviously, is the empowerment and the support for their family networks and their environment to support those choices as well. Alongside that, there's many other things that intersect. The provision of information, so you've got informed decision making. I'll come back to elimination of restrictive practice and PBS, positive behaviour supports, a little bit later. We're also talking from an individualised perspective, our contracting models have changed. My background is in procurement, And from when I started at the Commission in 2002 to now, it's completely miles apart. We've got the community services in partnership approach, we've got individualised planning approaches, and it is a very, very different system, which I think is a positive direction for individuals who are receiving services from us and supporters of service providers in the community. The other thing is around the quality framework, and you could pretty much do a 2-hour session just on the quality framework in the Commission. And that there you go, Commission, there's my first number one in the department. The quality system really starts from the get-go, right from our contracting model, getting people or getting service providers into the system and the registration process, right through to the ongoing review system and things like self-assessments and things like that. And we are moving from a contracting model to a registration model. So if there's service providers in the room that want to have a more of a conversation about that, I'm quite happy to do that as well. And also a lot of the conversations about workforce, and Sam in the opening address talked about the screening, worker screening, and that is definitely a national flavour now about how do we actually increase the overview of who is actually actively participating and supporting people in the community, and what's that's going to look like. On the other side of the tree, there's a lot of, I guess, policy frameworks and support mechanisms that have an indirect application to safeguarding, certainly from advocacy and the way advocacy is supported, the National Disability Strategy and information linkages and capacity building, which is another some really key foundational pieces around supporting the broader community, because a person doesn't live in isolation, they live within their networks, they access mainstream supports. And how do we actually join all those dots together, all the glue between all the things that get provided to an individual? There's also the direct government policy. So what does the Commission's policy say around supporting people? What does child protection and family and domestic violence policy say about protecting individuals? So a lot of those government policies that support that individual, and how do we focus that, again, that spoken word, how do we focus that again on empowering an individual to make choices and to represent themselves, or seek adequate and quick and appropriate supports when they need to. And also, obviously, the underlying foundations of law, and also other mainstream obligations. And thanks, Zell, for the idea around the DAPEs, because DAPEs, whilst they provide one mechanism, there is much broader that can be done around supporting mainstream services to continue to enable true participation and inclusion and supports within our community. So I know that's a very broad overview of many, many things around prevention and support. But also then there's the corrective elements, and there's the things like, I guess PAR sits almost between. So the People at Risk team, which is a team within the Disability Services, Disability Services Commission, 2. I was there. So I will donate. So the People at Risk team are a support to the local coordination team, where individuals are identified at being at risk, and that is in a number of different ways, from abuse to homelessness to financial, or to a number of other things. There's a team that supports our local coordinators in what to do in those situations. There's also the things like the serious incident reportings, which has a whole layer of safeguarding mechanisms within it. And of course then the things like SAT, OPA, complaint systems and things like that, which we've talked about. So that's a very broad lens, given Disability Safe Week, I guess, is our bread and butter, I guess, in a lot of ways. So there was a lot to try and cover. One of the things that we wanted to focus a little bit in on was about the positive behaviour support processes. The positive behaviour framework is a body of work that was done with a guiding committee and a lot of collaboration about 8 or so years ago. And the three key themes that came out about the positive behaviour strategy was about, again, knowing the person, knowing what their needs are, getting the services right around them, and that includes recruitment of the right staff, design of the right service, and including a positive culture, so the whole environment is supporting them, and also the importance of relationships in the community around them. The disability services, I've got to read this out because they've got the longest title in history. Disability Services Specialist Behaviour Support Consultancy Service, which is like, I know it's like a tongue twister, can't say that 3 times fast. They work with partnerships in the disability sector and within the community to support individuals, families and service providers on how to support the assistance of people who at times experience challenging behaviour. And that's a pretty strong flavour within our support service for that team, is to ensure that the environment that a person is within is well suited and well structured to be able to support their needs. This includes their support systems to reduce risk and develop their personal safeguarding strategies. They also have so not only challenging behaviours but complex needs, and I know there's probably some definitional things we can put around those. There's a lot of support that this team provides to the sector. There's a lot of uptake of the positive behaviour support team's work, which I think is really, really positive. And a key strategy that underpins that positive behaviour framework is the development of the Code of Practice for the Elimination of Restrictive Practice, another very long title. But that particular code is around supporting the service providers and the broader community to eliminate restrictive practices in whichever form, because there's lots, as you said, it could be seclusion right through to a number of other concerning factors, to eliminate those and look at more positive ways of supporting people through their challenges. The framework, I guess, has again those underpinning foundations around raising awareness around people's human rights, that the individual is the centre of the decision making, that they're the natural authority on their life and their choices, and putting appropriate systems in place for them to communicate their needs. Again, it's least restrictive, consent-based, short-time activities where actions need to be implemented, but also that forward planning so that you can prevent any concerns around how a person might need to be supported when they're maybe not at their best self. So that's an overview of some current work that has been driven for the sort of last 8 to 10 years and has been very much embedded in the sector at the moment. But I just want to touch on also the NDIS, hot topic, and particularly this body of work, which is the Quality and Safeguarding Framework. So for service providers who might be operating within this space, it's a really critical key document. And there's a lot of work, as it was mentioned at the beginning, there's a lot of work that's been put into the Quality and Safeguarding Framework. This is a national framework, and it has a lot of, a very broad reach, and has a lot of potential impact for the future of provision of disability services to within this state and across the nation. The underpinning foundations of the framework are 3 key areas: developmental, preventative and corrective. And what they refer to developmental is around empowering individuals to advocate and be supported, strengthening the networks around them. So really that underpinning thing that we've all been talking about, that if you have a safe person, you have a safe place. That's the best foundation for an individual to be supported. And then it's around the preventative actions around safeguarding, preventing harm, and then also responding if something doesn't go right, and how do we put those corrective actions in place. So I would encourage everyone to have a look at this, but also if you've got any questions as well, we can come back to those at the end as well.
Thank you very much, Simone. I think that the reason we asked Simone specifically to just talk a little bit about the positive behaviour framework and elimination of restrictive practices was that it's something I think that, as is mentioned in the NDIS, quality safeguards, and as we've been talking about all morning, that environment that people are in makes a huge difference to then vulnerability to abuse and neglect. So building the positive environments often means flipping around and moving away from a restrictive practice environment, or the, as I was talking about right at the beginning, wrapping people in cotton wool and hide them away, and building safe networks around someone. So thank you for that. And we now have Eleanor and Sergeant Steve Banks, and I think they're going to do a bit of a tag team, and they're probably known to be working probably at more of the hardcore end, but I think what's been really great about the Disability Safe Week that we've been doing was having the support of the police. You know, you'll notice in some of the posters that we've done and the flyers that we went and did some photos with the police so that would show the WA police uniform, because we think it's really important that people with disabilities know that the police are allies and people that they can go to for safety. So over to you, Eleanor and Steve. Thanks.
No, thank you for that. And I think that's a really important point to make, that we do want to be trusted and we do want to be, contacted. And so it was a really great opportunity to be part of that and to open up the Perth Police Station and invite some photos. And it was a really good experience for us as well. And I think, what's been said on the panel members, and I think as we're going to go down the panel, we're all going to start saying similar things. But, I'll just give you a bit of an overview. My role is within a division called the Community Engagement Division, and that's pretty obvious what we do. But really, its role is to build that trust and that relationship with the community. And I suppose it's there to say that you can contact us if you aren't getting a service from your interactions with the police, or you want to know what to expect when you contact police. You can come to us and ask us, what do we do? What should I do in this circumstance? And we're really there to help you with that. So I put some information out on the table for you as well. So Community Engagement Division are really there to assist people with disability access to services at WA Police, and we provide support internally as well. So I suppose it's about educating our employees about people with disabilities and what some of their experiences are particularly with abuse and neglect as well. So we can give our employees a good overview of some trends and issues. And as I said, we can also assist the community in identifying areas of concern related to policing and recommending strategies to overcome them. And what's been said amongst the panel members is, being a government organisation, we operate within a lot of policy and procedure and guidelines. That's partly what we do, and being policing is very much what we do. And my role is really looking at those policy and obligations and looking at where we can improve our accessibility. And those enablers are really quite powerful. And I know, what's been comments being made before, Iscel has mentioned about the Disability Access Inclusion Plan. I think my experience, I've been in the agency for over 10 years, mainly in policy roles and strategy roles. And those enablers are really important for a large government organisation to actually overcome some of those barriers in a practical way. And certainly from my experience, the reports like behind closed doors are very helpful to us. So those enablers, such as the Disability Access Inclusion Plan, are very, very important. They help raise those issues. It helps, I suppose, place a level of accountability so that we can have some transparency around those experiences for people with disabilities and make a commitment publicly about what we're going to do. So from my role as a policy person, I think that's really important to have that. I guess it's a good demonstration of an agency's commitment to overcoming, and I guess giving that voice to those experiences as well. So I guess our attendance here today is really to, you know, have part of this discussion with you all and to hear back from you about your experiences. You know, we have a lot of things in place in WA Police, such as our service delivery standards. Again, these are all these enablers. But I suppose what they're there to do is set an expectation in the community about your interactions with the police and what you should be experiencing from us. And I know we don't always get it right, and so those reports are really helpful to us. So, you know, moving forward, we are in the process of developing our new disability access inclusion plan, and your voices are really important to us. So, you know, we encourage the feedback. Unfortunately, you know, it comes about through oversight reports, which are not great, but if that's the best way we need to hear about it, then we need to take that on board. You know, feedback through customer contact surveys are really helpful to us, and we've included disability as an indicator in the national survey. So it's a national survey, all government agencies do it, but that's been really good for us to start, again, giving people with disability a voice and for us to actually see, because without the data we can't get a clear picture about what people's needs are. You know, the complaint mechanisms is another avenue as well, so we've also included people with disability as a marker in there too. So again, what I hope for over time is we can start getting a good picture about the needs of people with disability in their access to services, and through the development of our new disability access inclusion plan, that we can engage some of you in the community and the sector to give us some feedback and input. So I won't bore you with all of our different processes, but, you know, we do have standards in place. We also have our code of conduct as well, and that does mention specifically people with disabilities. So I suppose it's to reassure everyone that, you know, it's something that we do consider, it's something that we do hold ourselves accountable to, yeah, you know, we encourage that feedback. So I'll pass over to Steve. He can go through a little bit more operational matters.
Well, I just I hate talking into these things. I'm just not used to it. Look, I've been in the police force 29 years, and I've seen, yeah, I know, tell me about it. And I've seen a lot of change, and a positive change, and I know there's a long way to go, and there's still a long way for us to go in a lot of engagement, and we have identified that, and that's something that we need to take up, and that's what our role is, and that's what we will be doing. And I've worked in remote Aboriginal communities for over 5 years, and I've worked at major crime and organised crime, and obviously we're not there to obviously hand out flowers. We actually are there at the saddest times, so, and pretty much have seen it all. So I can really feel the importance in this room and where we're heading, and I'm astounded. I've been away doing some other things over the last couple of years, and I've come back and I cannot, I can't believe the improvement that has occurred in this area is amazing. Not only from government, but listening to these ladies here, it's incredible what's taken place. So, and we want to be a part of that, and we know where our shortfalls are, and we're going to make a difference in doing that. So I'm happy to take any questions after, and we can go through and help out. Just, I suppose, from an operational point of view, very quickly, with family violence, it's a huge issue for police. It's a #1 priority, and police officers are pretty much held accountable for their actions on when they attend these situations. They cannot leave that scene without sometimes authorisation from a senior officer, and then that report will be taken, and then it gets looked over, and then it gets sent for an inquiry. So the days of a report being taken, it just gets put to bed, have gone. They get inquired into. And depending on the level of the situation that's occurred there, it will be allocated to an officer to investigate, and he will be held accountable for that. And it's just the way it is these days. We're a more accountable service than we ever have been, and those investigations need to be conducted thoroughly, and then they get overviewed by a senior officer. So you'll find that our response units that just go to job to job to job to job. They'll take the initial inquiry. They won't necessarily continue with that inquiry. It'll be given to a local policing team to investigate or a specialised unit. So that's pretty much where we're at. But we know where we're at, and it's been a pleasure being here, listening to where we've moved forward in this area. It's great. Thank you. Sorry. Detention centres, as in... Look, it depends if obviously a complaint's been made. A complaint needs to be made, we investigate it, and then it gets taken from there. But, you know, obviously there's so many services out there that are providing help for these people that I'd like to think that they haven't got a problem in coming to us. It worries me a little bit in relation to the disability thing, that I'm hearing it a lot. They're worried about coming to us, and that we need to improve on that. And if that's about us communicating more or getting out there and start doing that, and I know that speaking to our unit today, I think one of them was going to the Deaf Society, I think it might have been out in Shenton Park, and that's happening today. So we're out there trying to make sure that communication's occurring and they can come to us. It's all yours.
Lucky last, Sam.
Thank you very much, Eleanor and Stephen. Yes, lucky last is Fiona, the gorgeous Fiona.
So you've done a great job staying engaged for this whole time. So I'm Fiona Payne. I'm one of the co-leads of the Disability Health Network. Can I just say a big thank you, Jane, to you. I arrived just as you were sharing your story, and the Disability Health Network was created really because people told their story, and then a big system like Health actually listened, and in partnership with the Disability Services Commission, as it was at that time, did make a difference. So thank you for sharing. It's not easy. You did a great job. It also reminds me of why I get up and go into the health department because sometimes it's not easy. So I thought, just in sharing with you what I can about the work that we're doing in health, I'd just talk about how health is organised, because I think that helps you to understand then some of the challenges of trying to influence the system, but also some of the opportunities. So health is a huge system. I think this is right, that it might be the single biggest government department expenditure. There's over 40,000 staff alone. But really importantly, people with disability are frequent flyers in the health system. So people with disability experience poorer general health than the average population, and so they use a lot of hospital services and health services in general. So this WA Health is organised into 3 different areas. There's the Department of Health, which is in Royal Street, which is the system manager, and that does all of the sort of buying services, developing policy for services, ensuring the quality of services, managing the staff, and those sorts of non-operational tasks. Then there's a health services support, which is kind of like the admin side of it. And now, since July 2016, there are 5 independently operated area health services. So 1 for the country, and then 3 metro ones, and the Child and Adolescent Health Service, which is also statewide. So they're all independently directed by boards, and they operate under services that are procured by the Department of Health. So that's a new thing. So it means that not only do you have to influence the system manager that buys the services, but you have got an opportunity to influence services locally as well. So the Disability Health Network was established from a clinical Senate debate in 2011, which is a process health uses where they bring together clinicians, patients and other people from the community to discuss particular issues and make recommendations about how the system needs to respond. So out of that debate in 2011, came a partnership approach to disability health, where the Department of Health and the Disability Services Commission committed to work together, create the Disability Health Network with shared resources and shared commitments from both departments, which is actually quite unique within health. We operate under the social model of disability, whereby it's not so much a person's impairment or the medical condition that they have, it's the interaction that that has with the environment in which they live that then creates a disabling condition and makes it hard for them to live an ordinary life. So that's a broader definition than, say, the Disability Services Act, but it's the one that's formed the basis of our WA Disability Health Framework. So when you're thinking about changing a big system like health, you kind of have to give people some guidelines about how that might happen. And we have developed, in consultation with the people that are part of our network, a framework and a resource to support the framework. And we are in the process at the moment of rolling that out to our within health, but also externally. So if any of you are interested in obtaining a physical copy of it, you are most welcome to come and take something from the goodie box here. And if you're interested in staying in touch with the work of the network, we've got some information here about sign up to be part of the network. So what the framework really does, I think of it kind of like as a washing line, which it just provides a scaffolding then for all of the services to think about what kind of things they need to do in order to improve health outcomes for people with disability. And the framework aims to do that by really providing some direction on the sorts of policy changes that need to happen within health, but also the way that services might need to be delivered differently, or services that might need to be created to better meet the needs of people with disability. It's really predicated on acknowledging that people with disability have the right to access healthcare that meets their needs, and that's actually enshrined in the United Nations Convention. It's also wants to achieve amongst health workers a much better understanding of the needs of people with disability. And so similar to the disability sector, where the focus is on, you know, the person and their family being at the centre of the support, so too you hear in health people talking about patient-centric services, where the patient is at the centre of all that is done and they are a partner in the healthcare journey with the clinicians who are involved in delivering the service. The end goal is obviously to improve the way that services are delivered, and ultimately that ensures that people with disability have better health outcomes. Through the network, we are involved with the Abuse and Neglect Task Force that SAM and PWdWA are progressing. So what is health doing, apart from this more generic work around changing the values base of health workers around disability? In March this year, the Clinical Senate that led to the formation of our own network held another debate, and this one was on interpersonal violence. And Sam and other people were there representing the specific issues for people with disability. And I think it's fair to say it got quite a bit of airtime, didn't it, Sam, which was great. So the Clinical Senate recommendations, and these are available on the Clinical Senate website, have gone to the Department of Health. And there are some of those recommendations that are about things that the system manager can do, so the area where I work, and then there are others that are around what area health services can do. So again, looking at influencing the system from the top down, but also at the local level. I'm not sure where the recommendations are up to. Kylie might have a better... No. So usually it takes a little while for them to filter through the system. But there is a specific group, there's a family and domestic violence reference or working group that is auspiced by the Women's and Newborns Health Service, and that has representatives from each area health service on it. So I would imagine that within health, that's going to be a pretty powerful vehicle for trying to make sure that these recommendations actually happen. And Kylie, are you with the, is SARC represented on that? Yeah, okay. So we've heard a lot of reference to the disability access and inclusion plans, and really what we have done within the health network is recognise that these are probably an underutilised tool in health, because while they have been very good at ensuring people's physical access to services, we probably haven't leverage them enough in terms of making services more accessible in the way that Zell was talking about. So each of the area health service sites actually has a disability access and inclusion plan. So they have a committee that's responsible for addressing the needs of their community, which includes people with disability. These are a mandatory, like a legislative obligation that these public health services need to comply with. And as part of that, they're actually required to go out and do public consultations. So it's a fantastic way for people from the community to influence the way that health services are delivered for people with disability. Probably the shining star in health in terms of our response to people with disability who've experienced family and domestic violence is through the service that Kylie runs, which is the Sexual Assault and Resource Centre. And so although she declined the offer to speak on the panel because we were looking for a whole of health approach, and Kylie's service is clearly very much at the grassroots delivering face-to-face services, the work that SARC does is actually, you know, exactly what we're talking about today. It's dealing with people who have experienced that kind of violence. And the way that they operate, I'll let Kylie explain if someone wants to ask some questions about it later, but it really is very consistent with that model of meeting the person where they're at and working with them then to actually be able to resolve the issue in a way that meets their needs and keeps them safe. So if you want any questions about SARC, Kylie is your contact person. Just in closing, I've talked about lots of ways that we're trying to influence the system from within. But I think one of the most powerful things that we can do is encourage patients or people with disability who are accessing health services to provide feedback about those health services. So as part of this new government's election commitment to health, they've introduced a new feedback mechanism called patient opinion. And the Health Consumers Council are very involved in rolling this out. But what this is a way that people can provide feedback to health services that is public. And so the health services are required to respond, and anyone in the community can see how that service is responding. They can understand what the complaint was. So in terms of leaning on the system from the outside and influencing it, I would encourage people with disability and those people who might be working with them in this space to again use patient opinion as another way to look at influencing the system. Thanks, Sam.
Thank you very much, Fiona. Now, I am aware that we've actually run out of time for any questions. However, the panel members are all here at lunch, and so I would encourage you, if you do have any questions, to have a chat at lunchtime and use that opportunity to get some more information. But also, the afternoon session is specifically about us being able to raise the questions that we have, to talk about the issues, and you know, we know that some of the questions and issues are the same across multiple sectors. So whether we're talking about it in an education context or the health context or disability services, we know that many of the questions are the same. and we want to be able to share that good information and share those issues. Zell?
Just while everyone's here, I do have a burning question.
Oh, we might be able to get just one.
Everybody's here.
Did you want to just grab a microphone there, please?
Thank you so much. I've recently heard of 2 cases where women have been raped. One was a domestic violence or family violence, domestic violence case. The other one was not DV. In both cases, the women were not taken seriously. They had reported to 3 disability services over their lifetime about 3 different incidents. None of them had been reported. Even if they were reported, it wouldn't get far. But the issue around here with these 2 is that it took about at least 2 weeks for a police report to come through. They didn't go through the usual process of when a report is made, and I'm told that involves some, taking swabs from the woman, DNA testing, so on. None of that happened. So my question is, what's going wrong, and how do we fix that so that we get immediate response and the same kind of consistent response that any other woman would get if they didn't have a disability?
Is there? I can see that Kylie is happy to have a chat. So this is Kylie Lawton, who is the director of the Sexual Assault Resource Centre.
Yeah, I'm the manager of the Sexual Assault Resource Centre, and one of the things that is interesting about working in the field of sexual assault is that we need to provide every single person that comes to us with an individual approach to their care. The Sexual Assault Resource Centre works alongside of the police. We are part of the Department of Health. We are not a justice organisation, but we work very closely mostly with the Sexual Assault Squad within the police department. And what happens is we have a range of ways that people can come into contact with us. So if you experience a sexual assault, you can go to the police and the police might bring you to us. If you experience a sexual assault, you can call us and you may or may not go to the police. If you experience a sexual assault, you might go to neither of those agencies and you might end up somewhere else trying to navigate the system from a different place. So referral points for sexual assault are quite broad and quite widespread. What we offer at our agency is a 2-fold service to people. If you've experienced a recent sexual assault, we have a medical forensic service that we offer to people. And that consists of a doctor and a counsellor providing you with crisis support. We only offer that support service and that medical forensic collection service to people who have experienced a sexual assault within the last 2 weeks. If more than 2 weeks have gone by since your assault experience, the likelihood of our doctors providing forensic evidence to the policing system is significantly reduced. So if your individual situation is that it has taken quite some time for you to get to the point where you need to be, or if your assault happened quite some time ago, our medical forensic service won't offer you the same range of services that you will get in other places. So what that means is that our doctors will talk to you at length about our consent process. Being seen by a counsellor and a doctor in the Sexual Assault Resource Centre requires you to be very, very aware of the service that we're offering. And we look at a range of medical treatments that can include things like management of possible sexually transmitted disease, pregnancy concerns, issues related to your health. Our forensic evidence, which is, as I said, limited and changes depending on the experience that you've had. And at the risk of being very blunt, what that means is the type of assault that you have experienced determines the type of forensic collection process that we can go through. And some experiences have far less time for us to capture forensic evidence than others do. So the counselling service that we offer is a psychosocial crisis support service in the first instance. But then at the end of that process, we also offer a second stream of contact with SARC, which is a counselling service that allows you to come in and spend some time with a counsellor talking about your psychosocial need and about your and really about doing trauma recovery work with people. So individual cases get treated quite differently. If you come to us through the policing system, the police will often accompany you to SARC. They will bring you to our organisation. They will talk to you about what they can offer. They'll encourage you to spend some time with us. If you go to the, if you come to us and you aren't sure if you want to go to the police, we can offer you a forensic service and put it aside and give you time to think about it. But it's not a necessity that you go from us to the police or from the police to us. In fact, sometimes it's neither. What we know happens in WA at the moment for everyone, for every person who experiences a sexual assault and comes through our system, is that we have a set of clients who come to us and the police have a set of clients who come to them, and there's only a very small combination of those people in the middle. So we know that sexual assault is much bigger than what our agency sees. It's much bigger than what the police see. What we also know is that for every person we see, we have triaged 2.5 other people. So we know that other people are calling us but electing not to come through our system and electing not to have their sexual assault treatment through us. The other side of the coin, and one that Fiona was kind of alluding to, which is about the size and scope of health, is that you can go to your GP and you can receive many services through your GP. You will not be offered a forensic examination service through your GP, but you will be offered a range of other treatments and service access through your GP, which is outside of the health system. It actually isn't part of the Department of Health in WA at all. So GPs are actually Commonwealth program, and your GP is a whole different set of health than the health that we talk about when we talk about hospitals and health services in WA. So I guess my really long and complicated answer to your question, Zell, is that it depends entirely on the pathway of that individual person. What we try and offer within SARC is an education service at a statewide level to agencies all over WA to try and encourage people to come to us, to consult with us, and to talk to us about people's individual need so that they can get the best advice possible. That isn't always amazingly successful. You can educate and educate and educate. Lead a horse to water, you can't always make it drink. But we do have specific funding set aside to provide that education across the community and to try and get other agencies to at least communicate with us, even if the person chooses not to come to our service. Does that cover it? I think I've covered most of it.
That was a brilliant answer. I think from what I might suggest is that I think there are some broader issues there as well, which Kylie's answer also highlighted, which we can then bring up in this afternoon's discussion, which is how can we ensure that when something does happen, all of the different stakeholders involved know that the role of the police and the role of SARC, and to ensure that people are actually having those choices and options to move to that next stage, because that might be part of what I think part of Zell's question was also about, where people maybe, whether it was through service systems or others, didn't actually get the opportunity when they should have. So I think that's a really important point for our afternoon discussion. Thank you very much, Zell. Can I just ask you to thank the panel once more before we then go to lunch?